On the luminal side, one we have our main guy, that is the sodium chloride. It's important. Another channel is for calcium, that is called TRPV5. TRPV5 channel, depending on the luminal side, it is for reabsorption of calcium. Now two channels present in the basolateral membrane, that is sodium calcium exchanger and sodium potassium ATPase pump. They are present on the basolateral side. This in the catch here is that this sodium, this proper channel for calcium, it was not present in case of thick ascending loop of Henle, where loop diuretics. There is no proper channel for calcium and magnesium, so they pass passive paracellular transport. And here there is a channel for calcium, so if calcium enters the cell, it will enter through this only. So normally what happens here? So it's simple. So first look at this receptor. Okay, this is the sodium chloride co-transporter. Its function is simple. It takes one sodium and one chloride ion from the tubular lumen into the cell. This is the transport is the target of thiazide diuretics, and in Gitelman syndrome, this transporter is genetically defective. Okay, so whether you give thiazide diuretics or if the patient has Gitelman syndrome, the effect is exactly the same. Less sodium enters the cell. So whether you give less thiazide diuretics, Gitelman, less sodium enters the cell is the point. Now what happens to intracellular sodium? Think carefully. Normally the sodium is entering through this channel into the cell. If we block this channel, now there will be less sodium inside the cell. Therefore sodium concentration inside the cell falls. Sodium concentration inside the cell falls. This is the most important event. Everything else happened because intracellular sodium concentration decreases. Now another pump we have, that is called sodium potassium ATPase pump. So sodium potassium ATPase pump is present on the basolateral side. Its job is to continuously pump 3 sodium out of the cell. Its job is to pump 3 sodium continuously out of the cell. Okay, so 3 sodium out of the cell and 2 potassium into the cell. This pump is extremely important because it also keeps the intracellular sodium concentration low. Now plus along with that, if you gave the patient thiazide diuretics or he has Gitelman syndrome, now less sodium enters the cell, sodium concentration inside the cell is already less. Now this sodium potassium ATPase pumps 3 sodium out of the cell. Now there is further decrease in sodium concentration inside the cell. Now there is further decrease in sodium concentration inside the cell. So after giving thiazide diuretics, the sodium concentration become even lower. Okay, so now what happens? The sodium concentration is extremely low inside the cell. So in order to maintain that, this NCX acts. NCX is sodium calcium exchanger. What is that? It absorbs 3 calcium ions from the blood into the cell and 3 sodium ions from the blood into the cell and pumps 1 calcium out of the cell. So this transport is called sodium calcium exchanger. It's present in the basolateral membrane. Remember the rule is simple: 3 sodium ions into cell and 1 calcium ion out of the cell. So 1 calcium ion moves from the cell towards the blood. Now after that, now the 3 sodium comes. Now the sodium concentration will be balanced inside the cell. But 1 calcium goes out here. Now there is decrease in calcium concentration inside the cell. So now the calcium which are present in the luminal side, they will come into the cell through this TRPV5 channel. So now this TRPV5 channel will be affected and calcium ions will come inside the cell. Sodium is balanced because this NCX balance sodium by pumping out calcium out of the cell. So the thing is that now NCX works harder. If you give patient thiazide diuretics or Gitelman syndrome, the NCX works harder. In the intracellular sodium is already low, so what will happen? It will try to rush sodium into the cell. If you try to rush sodium into the cell, you have to pump out calcium from the cell towards the blood. Since NCX brings sodium into the cell, it works more efficiently. More sodium enters at the same time, more calcium is pushed into the blood, so intracellular calcium is decreased. Now if the intracellular calcium is decreased, and look at the luminal side, we have calcium there. Another important channel, that is called TRPV5 channel. It is a calcium channel. Its function is to allow to calcium to enter the cell from the urine. Now if NCX is acting vigorously or it is acting aggressively by removing calcium from the cell, intracellular calcium is low, so there will be more calcium flow to the cell via this TRP5 channel, and this calcium will eventually move to the blood. So that what will happen, it increases calcium reabsorption. So in Gitelman syndrome, or if a patient is on thiazide diuretics, there will be hypocalciuria and hypercalcemia. Okay, hypocalciuria and hypercalcemia. So urinary calcium decreases, this is called hypocalciuria, and blood calcium increases, called hypercalcemia. So thiazides decrease urinary calcium. Okay, thiazide decrease urinary calcium, or thiazide causes, or you can say thiazide retains calcium. Thiazide retains calcium, loop loses calcium. Okay, so this is all about Gitelman syndrome, another thiazide diuretics. Let's me talk more about Gitelman syndrome. Gitelman syndrome is also autosomal recessive condition. There is defect in sodium chloride importer, and the RFT will be normal. There will be, as compared to the Bartter syndrome, there will be less sodium and water depletion in case of Gitelman syndrome. So there will be RAS activation, secondary RAS activation in case of Gitelman syndrome also, but it will be less. So there will be mild hypokalemia, mild alkalosis, mild polyuria, and another thing is that it loses calcium in the cell and causes hypercalcemia. If there is sodium chloride cotransport defect present in the DCT, it is also associated with TRP M6 defect in ileum. TRP M6 defect in the ileum. So this TRP M6 channel which are present in the ileum, it is responsible for calcium reabsorption from the GIT. If upon Gitelman syndrome associated with also this. So now if this channel is defective, so there will be less magnesium that will be reabsorbed from the fluid into the blood. So impaired magnesium reabsorption is equal to hypomagnesemia. Hypomagnesemia. This can also lead to tetany. Okay. Now here the hypercalcemia is there. The calcium concentration is increasing inside the blood because thiazide retains calcium. Or in Gitelman syndrome, there will be hypercalcemia, but there will be hypomagnesemia. This is the catch here. Okay, what is hypercalciuria? What is hypercalciuria? Hypercalciuria is when 4 milligram per kg of body weight of calcium excreted per day. Okay, 4 milligram per kg of calcium excreted per day. Suppose a 50 kg person, 50 into 4 is 200 milligram of calcium is lost in his urine. That is called hypercalciuria. So here there is no magnesiuria, because here in the in case of Bartter or loop diuretics, the calcium magnesium are simultaneously reabsorbed. Here there is only channel for calcium, so magnesium is not absorbed. So there will be hypercalciuria. Sorry, there will be hypocalciuria because it is absorbed, and hypomagnesemia because less magnesium is absorbed. Okay, so now let's discuss about the Bartter and Gitelman in more. So here is Bartter, here is Gitelman. So defect will know it is sodium potassium dichloride generally in the thick acid loop. Here is sodium chloride importer in the DCT. So polyuria, it will be more in case of Bartter, more severe in case of Bartter, less severe in case of Gitelman. And polydipsia, it is more severe in case of Bartter, less severe in case of Gitelman. Dehydration, more severe in case of Bartter, less severe in case of Gitelman. Growth retardation, more will be in Bartter, less will be in Gitelman. And maternal polyhydramnios is also seen in Bartter. Salt and water depletion, more there will be in Bartter, less there will be in Gitelman. Urine calcium excretion, more in case of Bartter, less in case of Gitelman. Nephrocalcinosis, more in case of Bartter because more calcium is in urine, less in case of Gitelman. Hypomagnesemia can be seen in type B Bartter or type 5 Bartter. It is more in case of Gitelman because associated mutation in TRPM6 channel, so there will be hypomagnesemia in Gitelman. So this is all the how it is calcium is handled in DCT and thick ascending limb, and their association with Batter, Gitelman, and all these things.